What is the Hepahealth II study and why is it important for Europeans?
Liver disease is a leading cause of mortality and working life lost in the European population. We know that the main causes of liver disease are alcohol consumption, obesity, and viral hepatitis. Now we have effective treatments to fight against viral hepatitis, but obesity and alcohol consumption are increasing. And in Europe, the alcohol consumption rates are the highest among all the world. If you are not doing anything, the mortality and morbidity in relation to liver diseases will increase in the next year. So it's important to start implementing policy measures to reduce alcohol consumption and obesity. In this study, Hepahealth II looked at the role of these policy measures to reduce the burden of liver disease and also to reduce the cost across 4 European countries.
What are the aims and conditions of the Hepahealth II study?
So because liver disease poses a huge burden on public health, EASL commissioned a study called Hepahealth II, which aims to study what would be the impact of different policy measures on the burden of liver disease with predictions, modeling and predictions to see the reduction in liver disease cases, liver cancer cases, and cost reduction by 2030. So this modeling included 3 countries, sampled countries, France, the Netherlands, and Romania. These countries were chosen because of their variability, epidemiologic variability, their data availability, and because they have different trends in alcohol consumption. It is decreasing in France, it is stable and low in the Netherlands, and it is increasing in Romania. So these 3 countries were modeled with prediction of liver disease cases up to 2030 in all kind of policy measure scenarios versus no policy measure scenarios called inaction. And we could actually evaluate the cumulative number of cases that would be saved if we use these different policy measures. The policy measures that were chosen were according to the major risk factor for liver disease, which is alcohol consumption and obesity, unhealthy diet. So we looked at 2 policy measures regarding alcohol, €1 minimal unit price, €1 minimal unit price policy measure, and also volumetric tax policy measure for alcohol. For unhealthy foods and drinks, we used sugar-sweetened beverages tax of 20%, and also restriction on unhealthy food advertising, especially on television at the times where children are watching televisions. All policy measures were actually effective. We looked at each of them separately, and we looked at the combination of the different policy measures all together.
What were the results found in the Hepahealth II study?
The results of the Hepahealth II study are that all the 7 policy initiatives will reduce the number of Europeans with chronic liver disease by 2030 if we implement them now. But they're not all equally effective. The results of our simulation shows that the most effective intervention is the €1 minimum unit price. It will reduce the number of Europeans with a chronic liver disease by around 7% by 2030 if we implement it now. With respect to liver cancer, reductions are slightly smaller, around 4 or 5%. But there are some who will say that a €1 minimum unit price is a bit too steep, and politicians will be reluctant to implement such a relatively high minimum unit price. They will also be very interested to see that the second most effective intervention is a combined intervention involving a smaller MUP, a 70-cent MUP, in combination with a volumetric tax on alcohol and a tax on sugar-sweetened beverages. It leads to reductions in the number of new Europeans with chronic liver disease of around 4%. So a sugar-sweetened beverage tax alone is around 1%. But the main message really is that all policy initiatives lead to reductions in the number of Europeans with chronic liver disease, with liver cancer, and it leads to reductions in the costs. So there are benefits to everybody. And now we can help politicians make the best decisions because they now have an informed choice. And that's really the main result.
What are the current opportunities at EU level to address obesity and alcohol consumption?
At the EU level, there are several opportunities to address the pressing issues of obesity and alcohol consumption. The first one that I'll start to talk about is a European Commission initiative, the Farm to Fork strategy, under the European Green Deal. And this was meant to provide a comprehensive legislative setup for improving nutrition and reducing the overall environmental footprint throughout the food system. Specifically, the strategy aims to tackle obesity by advocating for a balanced and sustainable diet. Within this strategy, the Commission planned and envisaged the framework for sustainable food systems, being the regulation of food environments as one of its main priorities. The logic behind the shaping of food environments is that healthy and sustainable food choices should be the most accessible and affordable for citizens. Another pivotal EU-level opportunity to address obesity relates to the revision of the regulation on the provision of food information to consumers, which plays a crucial role in ensuring that consumers are informed about the foods that they eat, again, enabling them to make healthier choices. On alcohol, the EU's Beating Cancer Plan includes actions to address alcohol consumption as a risk factor for cancer, aiming for a tobacco-free generation and reducing harmful alcohol consumption by 10% by 2025. Within the Cancer Plan, there are several initiatives that the European Commission has outlined, starting with a review of EU legislation on the taxation of alcohol and cross-border purchases of alcohol by private individuals. Following a study mapping fiscal measures and pricing policy on sugars, soft drinks and alcoholic beverage, the Commission is looking into the feasibility of proposing new tax measures on sugar and soft drinks. There is an element of looking into alcohol advertising, reducing the exposure of young people to alcohol marketing via monitoring the implementation of the Audiovisual Media Service Directive's provisions on commercial communications for alcoholic beverages. And two other elements within the Beating Cancer Plan, a review of the EU promotion policy on agricultural products, in particular, again, on alcoholic beverages, recognising that there is a tension there between promoting alcohol produced within the EU and the damage that it does when it is consumed, particularly in excess. And finally, proposing a mandatory indication on the list of ingredients and nutritional declaration on alcoholic beverage labels. At the moment, to my knowledge, there are only 4 countries in the EU that have mandatory health warning on labels, the most recent being Ireland, which introduced them earlier this year. And now if you purchase alcohol in Ireland, you will see a label on any bottle that is similar to what we are now used to seeing on tobacco packets.
What are the key barriers to implementing healthier policies in Europe?
The primary obstacle to advancing healthier policies in Europe is the significant influence of industry lobbying, particularly within the food and beverages sectors. This initiative around labelling on nutritional labelling on the front of any alcoholic beverage has encountered substantial resistance from certain industry factions and several national governments, as do efforts to mandate health warnings on alcoholic beverages. So this highlights this underlying tension between economic imperatives and public health objectives, with the former often overshadowing the critical need for health-centric regulations. And this gives rise to disparities in health policy approaches amongst member states. And so what we end up with is a very uneven adoption across Europe of strategies focusing on both reducing obesity and reducing alcohol consumption. At EFA, our commitment lies in confronting and counteracting the social and commercial determinants of health. Our goal is to drive change towards a more equitable and healthier Europe, where health is the main priority.
In your opinion, what policies should governments be prioritising for public health?
Governments should prioritise comprehensive policies that create environments that are supportive of healthy choices. And this starts by recognising a health in all policies approach, recognising that decisions involving planning systems, urban planning systems, that involve advertising, that involve fiscal policies, all have a health impact. And I'll give you an example. Within my home city, London, Transport for London has banned the advertising of unhealthy food across its networks in London. Regulating the setup of retailers to encourage the consumption of healthy and sustainable foods while hampering the purchase of edible harmful products. We've all been in supermarkets and seen sweets, confectionery, crisps at that eye level, particularly child height eye level, near the checkouts, near the tills. That is down to regulation of retailers and can be stopped almost overnight, should we wish it. Strengthening nutritional standards for food products and ensuring transparency through clear labelling. Investing in public educational campaigns to raise awareness about the risks associated with obesity and excessive alcohol consumption. Promoting physical activity through urban planning and support for active transport, and ensuring that health policies are evidence-based and protected from commercial conflicts of interest. And finally, and recognising the importance of this, implementing a mental health in all policies approach as well, recognising the links that there often are between alcohol consumption, unhealthy food consumption, and mental health. In conclusion, I'd like to say that non-communicable disease risk factors occur outside health systems and most are commercially determined. We need comprehensive sets of evidence-based regulatory policies to create living environments that promote health, not disease. And I'd go one step further and actually lift up people who experience socioeconomic vulnerabilities.